people are going to live the life that they live, and they're going to get injured or they're going to get sick, regardless of whether they have coverage or not. They're coming to the hospital.
They are. Welcome to Rural Health Today. I'm J.J. Hodshire, President and Chief Executive Officer of Hillsdale Hospital, and this is a podcast where we connect you, the listener, to what really matters the most in rural health. I'd like to welcome today's special guest, someone who I absolutely think is the funniest professional that I have ever met, at least at the MHA. But it is a pleasure to have Elizabeth Kutter for the very first time, correct?
Correct.
In our studio here. Elizabeth is the Vice President and Deputy General Counsel at the Michigan Health and Hospital Association. That would somehow reference that you're an attorney, which we'll talk about in just one moment. So first of all, MHA, Michigan Hospital Association, Michigan Health and Hospital Association, obviously. Talk to us about how long you've been there. What's the work that you do? What specifically does the MHA do?
Sure, absolutely. So first, thank you for having me. Longtime listener, first-time caller.
Oh,
Yay!
Thank you. Awesome.
It's very much an honor to be here. It's an honor to join you and talk about all of the things that are happening. So I've been with the MHA for about just a little over 4 years. So not a super long time at the association, but a long time in this space, in the political space.
You act like you've been there for at least 2 decades.
Oh my gosh.
I just want you to know that. I mean, you're well-rounded and you're grounded.
Longevity.
Is that okay?
Yeah, executive
absolutely.
President. That's probably what you're saying, right?
It is. It really is. Yeah.
Thank you.
I can just see it right now.
Oh my gosh.
Just think of what 20 years are going to bring for you. You'll be like just
Will it shock to you to know that I have worked in politics for almost 20 years?
Have you really?
Yeah, this is like your
I'm most
17.
interested to hear your background then, because I did not. I thought you worked for the MHA a lot longer than 4 years.
So I started with the association in 22.
Oh, wow.
Before that, I came from Wayne State University, so the state's only urban public university, one of the R1 research institutes in the state. Fantastic place, but obviously known very well for its medical school.
Absolutely.
And at the time, the president I worked under was an epidemiologist, so I did a lot of stuff in that space.
So what did you do? What would you do at the university?
State-based lobbying. So I did all of our
lobbying
at the
so you were lobbying.
state.
Okay.
I did all of our lobbying at the state, which is very budget-focused for the universities. That's what they do the most of. Prior to being at the university, I was with Henry Ford, so I was with one of our larger members on the east side.
Oh, you worked directly for Henry Ford?
I worked directly for Henry Ford, so I did state and federal lobbying at Henry Ford and spent a bunch of time there. Prior to that, I was on staff in the state and did healthcare, obviously did the Health and Human Services budget. I did a whole bunch of stuff in health policy. But that was honestly a bit accidental in nature. So when I started on central staff, I did things that were really fun, like tourism and natural resources. And then they were like, oh, you're kind of technical. Why don't you do financial services? So I did financial services.
So you jumped into that.
And then I did oversight. And they were like, oh, you're good at highly regulated. Would you like to do healthcare? And I was like, no.
You said no.
That's a trick.
Did you really?
That's a trap, and I'm not interested. I said no. So if you love that I'm in healthcare, you can thank my former boss who was at the state legislature. If you hate that I'm in healthcare,
you can blame
him. But
well, I want to thank him.
Yeah, you can thank him.
Because you've done a great job.
But I've done that for a long time. Prior to that, I did a brief stint out in D.C., and I spent some time.
Is that right?
I did. So I spent some time working for a member of Congress who has now since passed. But I worked for Dan Benishek up in the UP. He was congressman for the 1st District for a couple of terms. And then
Were you counsel, or what did you do?
Nope. I was just like an intern, just starting out my career in the space. Had never worked. It was post-law school, but had not worked on the federal side ever. So I worked there. And then I was working for a single issue organization for a while out in D.C. doing lobby work and supporting lobbying. And then before that was member staff in the State House and in the State Senate.
You're not that old, so this can't even be real. So, I mean,
I'm cresting 40.
Yes, oh, wow. Well, what a depth of experience.
Thanks.
And so a couple questions and follow up to that. So, I often hear that lobbyist, is that, can we call them lobbyists, right? That's like
I'm 66% evil and I accept it.
Okay,
it's okay.
all right,
I'm a lawyer and a lobbyist.
Okay, I mean, well, then that's 100%.
No, I'm not a legislator.
Oh, okay, that's how
I don't
you
have the trifecta. I'm just 66.
There is that, isn't there?
I'm 66%
Yeah,
evil.
okay. So do you find that a lot of the lobbyists are attorneys? Or what would you say is the advantage for you of having that background in the role that you play today? And I guess really talk a little bit about your role today. I mean, what do you do on a day-to-day basis?
Yeah. So I think that's not an uncommon path.
Okay.
It's probably 50-50 in the lobby corps of folks that have a background in law or folks that are
It's a lot of education.
Yeah, it is a lot of education, but it's a lot of people who pick that space because they're technical in nature, love words,
Yeah.
Like people that go to law school love words.
Yeah.
I love words. I love legal language. I love designing language. I love negotiating on things. And a lot of those elements that you're really focused on in law school and that they teach you in law school are the same things that apply when you really want to get good policy done.
Yeah.
It's figuring out when and how to negotiate something. So like, what's the timing? When do you give on something? Knowing what you can give or can't give. What are your hard lines? And what are the spaces where you're like, you know what, this one I'm going to let go. This one is a give. I'm going to give this one up, but this one I can't give up.
Right.
But I can move around some of the words here and get the same end result that I need. I love the language
So generally
negotiation.
speaking, if I could ask, in the background, what the community does not see is all of that work, right? They hear the rhetoric of the politician, or they see the final product, but in the background, people are actually putting this to paper, and it's words, and each of those words carry weight, and that weight has to be at times, obviously, or becomes the weight of law, but it has to be rooted in some type of legal parameters and those type of things. So there's a lot in the background that's going on that you're working on.
And I think that's why you see a lot of lawyers choose this pathway, because there's a couple really fun pieces of it when you're drafting anything in that space, or even recommending amendments or drafting law from baseline. Like if we have a member come to us, so you asked about what it is that I do a lot of direct lobbying. The vast majority of my job is direct lobbying. I get the extraordinary privilege of doing support work in the legal space and helping out in those realms.
So define direct lobbying. So you have been very, very involved, and we'll talk about it in a minute, but in some very key issues that MHA has advanced and advocated for on behalf of their members. Among those 340B and some of those,
combo of numbers and letter.
Right. And so, I remember you made me wear the pen.
Oh yeah,
it's at 340B. But that's a lot, right? But that looks like what you're actually knocking on the door, and you're actually educating, training, advocating.
It's exactly what it sounds like. So direct lobbying would be me going into a legislative office, knocking on their door, going in and talking to them and saying, I need you to take this position on this piece of legislation, and asking them to vote in a specific manner. So there's a huge difference, right? There's two things that are occurring in this space that people, I think, oftentimes conflate. So there's advocacy. Advocacy is like a big umbrella. When you come for an advocacy day, or you come and do things in the community, and you're talking to folks about the important issues that are impacting here, like if you're talking about Hillsdale Hospital and you're out, say you're tonight at the rodeo, and you're out and you're talking to folks.
How did you know that?
Oh my gosh, I just read the calendars. I just am really into what's happening in the community, always looking for a fun Friday night event.
And see my hat over there, yes.
Oh my God, it's beautiful.
Yes, thank you.
Pink is totally your color.
I hope it stays here, but I have a feeling it's
Do you have some boots?
I do. Yes. It's
Are
going
you
to be
square toe?
No.
Pointed toe boots. All
I'm
right.
going to try, but I've never worn them before. They say they're going to hurt my feet.
Really?
Yeah. I don't know.
Did you buy the wrong size?
I think I probably did, because they don't feel comfortable.
Do you have a podiatrist on staff?
I do. I feel defeated when I go to her, but still. And then I have to get on this. I guess, is it a donkey, or maybe it's a horse? I don't know what it is.
Mini horse?
Mini horse, maybe.
Ooh.
So I don't know. It's going to be a fun evening, but we digress again.
Yeah, but that's going to be fantastic.
Yes, it is.
But so if you're out in the community, so say you're out at a community event, you're talking to folks about an issue that matters to you, that matters to the hospital, and that matters to the industry.
Right.
And you're saying like, hey, 340B matters to me. I care really deeply about this issue, and I want you to know what it means for Hillsdale Hospital in particular. It means these types of services. It means these types of things. It is why we are here. We're a community asset, and this helps keep us in that space. Yeah. You're being an advocate. You're doing a great job making sure that people understand the issue, that they're talking about the impact it has locally, and that they understand what their local hospital is experiencing. You're not direct lobbying, even if you're meeting with your local state representative or your state senator.
Right.
If you're meeting with them, it's not part of your everyday job, and you're not, spending all of your time doing that. You're advocating globally for the issues that matter to you.
Absolutely.
And everybody should be an advocate. And this is me saying everybody should do that. Everybody should go to coffee hours. They should go meet with their legislators, meet with the candidates, and find out what's going on. Yeah. Everyone is an advocate. Not everyone is a lobbyist.
It's true.
The vast majority of my job is spent directly communicating with legislators and asking them to take a specific position or a specific vote on a specific issue.
Yeah.
There's a huge difference in that I'm not doing just global education, which we do a lot of.
Right. It's targeted towards
but it's very
matters.
much like I'm going in, I'm talking to a legislator, and I'm saying, hey, I want you to vote yes on Senate Bill 94. Senate Bill 94 matters to our members. That helps us protect contract pharmacies in the 340B space. It protects us from encroachment in this program from pharmaceutical manufacturers. I need you to vote yes. Voting yes matters to our industry and to our membership.
Right.
And then, the legislature can say any number of things. We'll have a back and forth
based on there.
conversation.
Oh, sure, absolutely.
But because over 50% of my time is spent doing exactly that, asking somebody to vote a specific way on a piece of legislation, then that would be, I'm a lobbyist, I'm registered, I am under the law, a regulated entity. I have to file reports semi-annually that say, this is what I've done, this is who I've been around.
Right.
Because there's not.
You have to, right.
Yeah.
Accountability.
Accountability matters a ton. And I think, again, the sort of common misconception nationally on what's a lobbyist, what's an advocate, and making a joke about being evil is very fun, but
really
truly,
what it is. Yeah.
Yeah.
But I mean, really, what is it? And you've defined it today. It's an art.
Yeah.
And you are representing the interest of your members at MHA, but it's got to be tough at times, though, when you're dealing with members who might have differing interest. That's hard, isn't it?
Yeah. So it's very different having come from the individual hospital side.
Right, because you knew exactly 100%.
Exactly.
This is what we're going to do.
Or this is what we're doing in this community.
Yeah, absolutely.
Or this is the individual issue that we're we can use, it's a good example. We'll use CON as a really prime example. Certificate of Need is something that everyone in the industry understands. But largely the association doesn't get involved in because it really is individualistic in nature. Folks are fighting for an opportunity to really make sure that either A, services can be offered in a specific space, they can add services or move beds around, add beds, any number of different things that sort of deal globally in us operating as entities in the community and being able to offer services. But we don't as an association get involved because our members are often not aligned.
Right.
So association lobbying, and I'll give the association an incredible amount of credit because this is a leadership structure and a leadership down sort of endeavor from the board level all the way through the entire association. We operate on consensus. So when everybody is aligned, that's what the association goes out and does.
Sure.
If our folks, at the board level, if our folks at the legislative arena level in the policy space say hey, one entity wants this and another entity does not, we're not picking winners and losers. That's not appropriate. It's not our job.
Right?
No.
You can't.
And it really would, I think, lower the effectiveness of the association.
It would.
Because it puts us in a bad spot.
Yeah, it's an incredible amount of walking the line. Certainly, hospitals have varying opinions about whether it's mergers and acquisitions, CON. But I have to tell you, MHA is remarkable in the work that you guys do. To ensure that I still, even if there's differing opinions you're still representing me in so many areas.
Yeah.
And we're going to talk about that in a minute, about some of the work that you've done this year that has been monumental to the success of hospitals, large and small. And we'll talk about that in just a minute. So healthcare experts, and as we look and try to brief healthcare experts, they're telling us about what the future is going to look like. It's going to be ugly. It's going to be nasty. 734 hospitals at risk of closing, half of them at immediate risk, 20 in Michigan. It's happening all around us. And the root of this is that we're not getting paid like we used to get paid, or the reduction of certain programs such as Medicaid. So healthcare expenses continue to outpace cost of living, creating more of a significant financial burden and strain for hardworking families across the United States. I'm excited that you're here with us today, Elizabeth, to provide your insight on advocacy and funding for healthcare, because I think that's important, specifically to Michigan and working with the Michigan state budget in the Michigan state government. So today we're going to talk about Medicaid cuts, state budget priorities, and of course, what all this has to do with rural health. So why don't you tell us a little bit more about the incredible work, and I say that with sincerity, the incredible work in state advocacy that you do with the MHA, and what your current key goals are in that context with policy meetings and discussions with legislatures. What's it look like today?
Yeah. I mean, I want to go back to some of your earlier comments because I think it is really challenging for the average person to feel like my vote matters, my discussion matters, the email I sent or letter I sent or the call I made to my legislator matters.
It's tough.
But I do want to reiterate, just despite the fact that globally the tenor is super political and it feels really far away and it feels really like things are happening and they're not connected to local communities, your legislators do deeply care about those things. Please continue doing those. Please continue to write emails and write letters and talk to us. Tell us what's going on, because I don't know what the priorities are unless our own members are talking to me about what's impacting them.
Yeah. Do you often have legislators tell you, well, I've heard from constituents.
Oh, yeah.
Is that a common,
Yeah.
is that used as a litmus for them, or how are they
yeah.
using that information? Just to give our listeners an understanding.
Yeah. So like when I was on member staff, when I worked for a legislator, when I worked for an elected official, I was the person when you send an email, I was the person that went through all the emails in the email box and was like, okay, this one's a healthcare one. It goes to our healthcare person. This one is a natural resources one. It goes to a natural resources person. Or if it was a constituent inquiry in a topic area that was one that I covered, then I would do the research and respond to that individual. But we answer and keep track of every single thing that comes in through the office. And it really isn't as many as people think before it's like, oh, this is an issue we're going to have to really think about and talk about. It's really only, 5 or 6 emails or calls from your local community, from folks that either A, elected you or didn't, but that you represent.
That'll start to catch attention?
Yeah. It's really only about 5. And you get about 5 and you're kind of like, all right, we got to dive into this a little bit further.
Really?
Like, what's going on here? What's the issue? What's happening? And at that point, that's when you as staff are going to reach out to the stakeholders that you know. So you're going to reach out to the association or to your local hospital.
Yeah.
I mean, you experience this.
We do all the time.
Your own local legislator reaches out to you
absolutely.
on a really regular basis. And that's exactly what you want. And that's the whole reason that it's really important to do those letters, to do the call, to show up to the coffee hour, to be present for those things.
Yeah.
Because you're not able to develop that relationship unless you're willing to reach out.
Yeah.
But I digress on that space because I think that the
No, it's
engagement...
It's an important point.
Yeah,
It really is.
the engagement part is the biggest piece of everything that's happening in politics. Like, nothing in politics is going to continue to get better if people don't deeply care about it.
I agree.
It's such an opportunity for you as an individual citizen and as a resident of Michigan in particular to say, I do or don't like the path we're on. And then to vote with your feet. I mean, people vote with their feet in any number of different spaces. Our elections are the best way that you as an individual have the opportunity to say, I do or don't like what's happening. But you asked about priorities, things that we're working on. So the biggest priority right now in this timeline is going to be state budget. So the state is really actively moving in that space right now, which is very fantastic because we're a little early on the timeline. You may recall, your listeners may recall, if they're political nerds like me, last budget cycle, we were way down to the wire. I mean, we didn't even...
wasn't there a 2-day...
we shut down for a couple of days.
Yeah.
I mean, we really did not even get serious about a budget until August,
What
September.
was it, July, August? Okay.
Yeah. I mean, it was probably August where we saw the House release a chamber budget that was really deeply, threatening to hospitals and to healthcare. Thankfully, not the same case this year. We've got 2 budgets, both out of the House and the Senate, that fund the Department of Health and Human Services in ways that are much closer to what we would anticipate from a traditional
With support
setting.
on both sides.
Yeah, I mean, like right now we're seeing, a state house budget in the DHHS space that largely funds all the hospital lines and Medicaid pretty close to full.
Yeah.
And then we've got a budget on the Senate side that does fully fund it. So when you're thinking about a negotiation, when you're thinking about, like, I'm an attorney, obviously we talked about that. When I'm thinking about a negotiation, if I'm in a space where the differences are significantly narrowed, I'm looking at outcomes from a much more positive stance.
Sure.
Like, the outcome is much more likely to be closer to what we want to see than when we started last cycle.
So
and
you feel encouraged?
Yeah,
this
I do.
budget cycle.
I
You
feel
do.
optimistic. I'm going to manifest that for us because I feel like that's a joyful
good.
thing to do.
No, it's a very
and
good thing.
It's been a beautiful day and it's a Friday.
We often talk about all the negatives, but it's great to know that there's a shred of hope.
Well, yeah, I mean, and you should offer gratitude. When people are doing things that are
Absolutely.
going well, I'm going to offer gratitude to that because I think the legislature's done a really good job this year of being really serious about the budgeting process. And you're right, there are a lot of threats out there. And I think the legislature is taking that seriously, and they're asking us and asking other stakeholders, how do we make up these revenue losses? I mean, whether you like H.R. 1 or you don't like H.R. 1, obviously our industry is pretty concerned about H.R. 1. It's a really serious threat.
yeah.
Like, we're going to lose an incredible amount of money. There are going to be an incredible amount of people, who are going to lose access to care, whether that's because they lost coverage or because their local hospital could not sustain it. I mean, that is a very real threat, and it's a very real threat to the state budget.
It is.
But I'll give credit on the state budget side. I think the legislature is doing a good job of thinking through what are revenue generators.
Right.
What are savings that we can recognize that
not
are not
necessarily
going to impact
tax increases.
Yeah,
but
exactly. Like, but looking at, like, okay, what are our structures?
Right.
What are we doing within the confines of what we have? What are savings that we can find? Like, one of the cool and creative ones that I saw on the Senate side was reference to most favored nation pricing. Lots of people are familiar with most favored nation now. Certainly, the federal administration has made that a more kitchen table set of terms. Versus, I think if you had asked anybody, a year and a half ago, what's most favored nation, they'd be like,
what? Hello?
America?
Yeah, what is it? Yeah,
like,
I mean, it's
I'm
us.
favored.
Hello,
We're the most favored.
I like it.
Yeah, my house. I'm most favored nation.
Yeah.
Like me.
Favorite?
Yeah, I'm the most favorite daughter.
Absolutely.
Yeah,
You're the
exactly.
only, right?
Oh, no.
Oh,
no,
is there more?
I have a sister.
Oh, okay. All right.
I'm the favorite eldest daughter.
Okay, there you
probably
go.
would be
She's
what
the
my mother
favorite
would
youngest
say.
daughter.
Yeah, she's the favorite baby daughter.
Understandably.
Yeah, exactly.
But probably
Just like,
not nearly as funny.
Oh, she's a trip.
Is
I'm
she
never
really?
going to
Well, let's bring
besmirch
her into the studio.
I love my sister. She's
All right.
the best.
All right, let's bring her in for the next podcast.
Okie dokie artichoke.
All right, good.
So, but if you're thinking about it, like, those risks are very serious, and those risks are very, like, challenging to wrap your head around when you're a state-based legislator and you're like, okay, cool, but why are our revenues so low?
Yeah.
Or why are we making these massive caseload adjustments and estimates? What is it that we actually need at the state level to fund the right amount of folks to hire, as well on top of the folks to hire, like the money to support them to implement work requirements? I mean, the work requirements are coming whether you like them or not. What we need to do is make sure we do it really well so people don't lose their coverage. Because when people lose their coverage, they're not going to stop getting sick.
Absolutely not.
Like, I mean, you know this better than any other person.
And where are they going to present?
Yeah, they're going to come to the emergency room.
Absolutely.
They're not going to call up their primary care doctor and ask for the cash pay option.
Yeah, they're not going to.
No, they're not going to be like, hey, do you accept no insurance?
Right.
They're not going to start running and eating exclusively vegetables.
No.
Like, that's not going to be the case.
No.
People are going to continue to live the life that they live.
Yeah.
Whether that's healthy or unhealthy, that's not a value statement or anything like that. But, like, people are going to live the life that they live, and they're going to get injured or they're going to get sick, regardless of whether they have coverage or not. Right. They're coming to the hospital.
They are. I want to get in the weeds in a minute on some of those issues, and I'll be cognizant of our time. But right now, when you're working with the state legislature today, like in this hour, what are the budget priorities for the state? And I want to move beyond right now healthcare. I want to get in the weeds of healthcare, but like, what are the top priorities that what would take precedent over a healthcare fund? Total package is what are you hearing in Lansing today?
So I think on the House side, the big priority that the majority caucus has talked a lot about is property tax relief. Okay. They're really looking for ways to make sure that as a state, we can look at eliminating our state-based property taxes.
And that's gaining a lot of traction.
Yeah.
They're looking at Indiana as really the reference state for some of that.
Yeah.
But that's a priority.
Yeah.
But you have to generate revenue somehow.
Sure
then
do.
The opposite side of that argument is, where does that come from?
Sure do. But if you're a member of the majority caucus in the House, what you're thinking about is not necessarily replacing that revenue with new revenue, but instead really looking at what are the places in state government that could be leaned down, which is a risk that we're always very cognizant of because people look to healthcare first to take those dollars out and say like, we heard this rhetoric a lot at the federal level around waste, fraud, and abuse. Yeah, exactly. And I think you hear that at the state level too.
Very easy talking points, right? Who doesn't want to rid waste, fraud, and abuse?
Yeah. Well, it's same as, it's very similar, I think, as the talking points around affordability.
Yeah.
Everybody is recognizing that things are expensive right now. Gas is expensive. Eggs are expensive. Groceries globally are expensive. Infrastructure is expensive. Like,
it is.
The housing market is changing. Everything that people are experiencing is very expensive. So there is this sort of very large scale conversation happening at the state and federal level around affordability. I would say on the Senate side, you asked about priorities. So House side, affordability occurs on both sides. Everybody's looking at affordability. They're approaching it two different ways. House side, they're looking at, all right, if we can offer property tax relief, this is a space where we can really try to help people out.
Yeah.
And I think there was, a pretty strong endeavor and has been a strong endeavor in and around income tax relief and reductions. We had some work maybe in the last couple years where the state passed some legislation that if the state had appropriate revenues, the income tax would automatically trigger to go lower. Yeah. And we achieved that for a year. It's gone back up now, but I think there's this sort of consistent interest and endeavor to go at income tax relief, at property tax relief, at those very day-to-day things people would see. Yeah. It's an attraction opportunity from a state perspective. People always look at Florida because they're like, they have no state income tax. I want to move to Florida. Yeah. Same with the property tax piece. We're trying to be not a net exporter. We talked again about healthcare and what happens when people lose coverage and what happens when HR1 really becomes implemented. Michigan is an aging state. We're not a state that's attracting a ton
No,
of
we're
young
not.
people.
No, we're not.
Our median age has escalated from, I think, like 10 years ago, it was like mid-30s. Now we're looking really more at mid-40s.
Yeah.
We're not getting younger.
It's not going the right direction.
We're a net exporter of talent.
Yeah.
We
absolutely.
educate an incredibly fantastic amount of people, and then they leave.
They go.
They go away.
Yeah.
But their parents stay. Folks here are older. They're not.
Yeah.
They're not. I'm an outlier in this case because I've got 4 kids, so I've got heirs and spares.
Yeah. Okay.
Yeah. I've got extras.
That's hilarious.
Yeah,
I like
thanks.
That. That's a great way.
Again, the BOGO baby helps you get to heirs and spares really quick.
No doubt.
So people in Michigan are aging,
Yeah.
and that's causing a lot of stress on
It
the
is.
healthcare system too,
Yeah.
because those are patients who are going to
Larger
present
consumers of,
yeah,
healthcare.
and they're people who are going to have more complex health issues.
Comorbidity cases.
Yeah, I mean, they're
absolutely.
people that are going to have heart disease. They're going to have diabetes. They might
All
be
the above.
individual who have they might have cancer. They might get a cancer
Yeah.
diagnosis and already be navigating these other
Yeah.
systems, and that's not going to change.
Yeah.
The challenge again is that while folks are really focused on delivering these kitchen table affordability items,
Yeah.
the
What
first place that we have a tendency to pilfer
Yeah.
is in that healthcare setting. So we're always really careful about
So
that.
I want to talk about. I've never had to preface this with you, but I'm just going to say it as I want you to be honest. You always are.
Oh my
brutally
God.
honest.
I've been accused of being overly direct.
Yeah, well, but that too. But still, brutally honest is what I enjoy about you most. But I want you to be truthful on this podcast about what is the attitude towards healthcare in Lansing right now at the state capitol. And we have to warn my colleagues across Michigan, but this is a national podcast. So it's not just happening in Michigan, I would venture to say.
No.
Talk to us about what is the attitude towards us.
Yeah. So I think it's interesting. Michigan is always a really great bellwether and sort of a microcosm. Like if you're thinking about what's happening nationally, what does the national scene look like? Michigan has always had a tendency to be a good example of what's to come or what could be happening. Right now, we're obviously a very purple state. So we have a House that's controlled by Republicans. We have a Senate that's controlled by Democrats. We have a governor that's a Democrat, which means we get this very interesting dichotomy of approaches and an interesting twofold set of like what people think. Right now, what we see on the House side is probably closer to what we see at the federal level too, but it's not unique just to that chamber.
No.
I mean, people are, and again, you asked for my brutally honest opinion.
We need it.
People are not friendly to hospitals.
Yeah.
There is a common perception that hospitals are greedy, that hospitals are bloated, we're a part of the waste, that we're billing and overcharging and then just taking all the money and we've got some secret hoard of gold like a dragon and we sit on it.
I want to find that.
I mean, if you find the dragon,
I'll let you know.
You will,
Okay,
then you will find the gold.
Because I will find the gold.
Yeah, then you will, or like a leprechaun. It really depends.
I think they're dragons anymore.
I think it's a dragon. I'm really I'm a fantasy girly at heart.
Yes,
so
so it's got to be a dragon.
Dragons or like a fire drake. It could be a fire drake. They're big hoarders. They love the gold.
Yeah, I'm going to look for that tonight.
Yeah, I think you should. I think you should. Yeah, it's probably where the gold is.
It's probably where it is.
But yeah, I mean, there's this common perception that hospitals are super, super wealthy.
Do you think that's on both parties?
I don't think it's unique to one party.
Okay.
I think there
is
some
sentiment on both sides.
Well, yeah, I mean, think about it. Everyone knows what a hospital is. Everyone has been to a hospital, gotten a hospital bill.
Oh, sure.
Received care in a hospital setting, had a family member that had care at a hospital. So it's a really easy space for people to target, for adversaries in particular. Like for someone who's trying to point the finger away, and I'm old school, so I'll always offer the caveat that if you're pointing the finger at somebody, you're pointing three back at you.
Exactly.
So I think when people are pointing that finger at us, it's because those three pointing back, they're trying to distract from.
Yeah.
And that's common. I think we see that a lot with folks who are adversarial.
Regardless of the issue,
Yeah, but like in healthcare in particular, because it's always real rich coming from entities where I'm like, all right, cool. In Michigan, dominantly hospitals are nonprofit by nature.
By nature.
Like that's the case.
It is.
Every one of our hospital
Which is under
members,
attack right now.
Your nonprofit status is always under attack.
Absolutely.
And that's an unbelievable thing in my opinion, because the amount of good that's happening and what we're doing is just really wild.
Yeah.
But I think you see this sort of rhetoric from folks that's like, oh yeah, they serve lobster and they've got all this money and their hospital executives make too much and you got this big bill and how cruel of them. But in reality, the real difficulty is explaining the complexities of healthcare.
Of how the bill even gets to their
Well, and in politics, you know that if you're explaining, you're losing.
Yeah.
It's a lot easier to point the finger.
Rhetoric is so fun just to say, look at your hospital bill.
And there's a lot of
people
You
paid $27 for an aspirin.
Yes, exactly.
You know?
And look at this ridiculous facility fee they tacked on too.
They tacked on, yeah.
And it's really challenging to try to explain to somebody the intricacies of healthcare financing. It's not cut and dry. It's not an a la carte service. Like you can't, it's not like going to McDonald's where you're like, oh, well, I've got $5 in my pocket, so I can't get an apple pie today. I can just get my double cheeseburger and a side of fries. Like you don't pick and choose. You also don't, this is, again, maybe more my own personal opinion on this one, like you don't shop for healthcare services in the hospital setting in particular in the way that you shop for other things. If I have a constrained income by any stretch in any space, I can say, all right, we can go to the nice dinner because I've got $50, or I'm going to go get fast casual because I've only got $20. And I can shop around for what's going to make sense for my budget, what makes sense for what I want. But if you're in a car accident, you don't shop for those services. You're taken to the trauma location that can handle what you have going on. And you're taken to the closest one, hopefully. I mean, like, depending on volumes and depending on what could be happening. I mean, we saw this in the pandemic. I mean, people were going everywhere because it was wherever we could treat people and had the capacity. But you don't shop for services in the healthcare setting. So it's always really challenging when that rhetoric comes around because we're really focused on reminding folks that hospitals serve a very deep community purpose. We're the only leg of the healthcare stool that's subject to EMTALA. So if you present in the emergency room and you come in, we have a legal obligation, but also a mission-based obligation to serve you, regardless of payer status or anything else. Like, no matter what happens, you're going to get service at your local hospital. You don't go to your local pharmaceutical manufacturer. They're not going to fix your broken leg. They're not going to help you or your mom when they have a health issue. Like, that's just not the case.
Not going to happen.
I think the real good benefit, though, is despite this, sort of national rhetoric that's very challenging and forces, I think, all of us to be better about talking about what are we doing in the community? What is it that we do to serve? And who is it that you call? Who do you call when something goes wrong? I call my local hospital folks. I call my local provider.
Sure you do.
I call the people that I know that are going to take care of me.
Take care of it.
Yeah. And I think one of the positive things that we continue to see, though, is there is still this really deep connection to your local hospital, your local provider, your community anchor.
People you see at the grocery store.
And I'm a lobbyist, so I'm going to lobby all of you to be very involved in politics because it's super fun. Get to know those people.
You have to.
Because they're going to call you.
They will.
And I want them to call you. And I want them to call your community members and your friends who are going to speak positively about what's happening in the community. Because people who care about their local assets are going to protect those assets at all cost.
Thank you to our listeners for tuning into Rural Health Today. Catch our next segment, Rural Health News, to stay up to date on the current state of rural health every Monday, wherever you get your podcasts. Don't forget to check out our latest updates and resources from Rural Health Today at ruralhealthtoday.com, and make sure you've subscribed to the show so you never miss an episode. Until next time, remember the power of rural.
Thank you for listening to another episode of Rural Health Today, the podcast where we connect you to what really matters in rural health. Rural Health Today is a production of Hillsdale Hospital in Hillsdale, Michigan, and a member of the Health Podcast Network. Our host is JJ Hodshire, our producer is Kirsten Newlon, and our audio engineer is Kenji Ulmer. Special thanks to our guests for sharing their expertise on the show, and also to the Hillsdale Hospital marketing team. If you want to submit a question for us to answer on the podcast or learn more about Rural Health Today, visit ruralhealthtoday.com.